Welcome, welcome. We're very happy to have you here. This is our third monthly seminar for pediatric stroke education. I'm Mara Yale. I'm a parent supporting parent education with the team from MGH. And we're just gonna allow people to join. We had almost 250 people register today, which is super exciting. Today's topic is visual processing, and it's actually going to be a two-part topic for today and then January. We'll share the date for January once we settle that, but our colleagues from Perkins are also on this call and will be leading the session in January with more, I think today is more theoretical or understanding what's happening in the brain, and January will be more practical, like how to work in the home and in school. So we're just going to give people a few more minutes. If you're just joining, add where you're from in the chat so you can see. And the way that our agenda works, we'll first have a parent story. Gretchen Murphy is going to talk about her son and their journey with visual processing. And then our expert today is Lotfi Meribet, and he's going to explain cortical visual impairment from a brain science point of view. And then we'll open it up for questions from you. So feel free as you listen to both Gretchen and Lotfi to put questions in the chat. But when we do open it up for questions, we'll invite you to come on and ask your question out loud if you're comfortable with that. Wow, we're quite international. Egypt, Ontario, Paraguay, Nova Scotia, lots from Massachusetts and other parts of New England, but also all over the US and globally. So I think, well, we're still getting people joining. Well, let's keep to time. It's 9:06 here on Eastern time. So I will hand it off to Gretchen, who's a fellow mom supporting these education efforts from MGH, sponsored by MGH and the community. Thanks, Gretchen.
Thanks, Mara. Hello, everyone. Welcome. I'm here to share our son's journey today and to introduce our speaker. Just to start out, this is my son, Owen. He is a 5.5-year-old, very spirited little boy. Now for all of you parents out there with pediatric stroke, all your mom and dads, you know it's very much a journey that is individualized to each and every child. So while we have done a lot with Owen, I am going to be focusing today on our vision journey and what we are doing as parents to maximize his development opportunity. So I'll give you a little bit of a background about him and our journey. So Owen was born at Mass General Hospital in May of 2015, and we knew within the first 24 hours of birth that he had suffered multiple strokes at birth, so impacting various areas of his brain. And so he immediately went into EI, like many children do. Early intervention, for those who are outside of the US, is state, I believe it's state run, and they sponsor all the development needs of a child through age 3. So in regards to Owen's vision journey, we knew that one of the strokes impacted his visual processing part of the brain, but we weren't worried about him seeing. He was evaluated by Perkins through the EI process, but at age 2, at his pediatrician appointment, his 2-year-old checkup, he failed his vision test. And that's what started us on the vision journey. So upon that that failed vision test, we were referred to an ophthalmologist in the area, and he was put in glasses. His eyesight then was about 20/60, but it progressively got worse between 2.5 and a 3.5, 4. He got to 2200. So as part of his, what the doctor had told us to do is we've spent a lot of time patching his good eye. And for the last 2 years, we've been working on patching and or drops to get that vision from that 2200, which was the worst that it was, to right now where we're at a 2050 bordering on a 2040. So we did a lot of work in that area. During this time, this past summer, in August of 2020, we had our yearly stroke visit. So Mass General Hospital has their pediatric stroke clinic led by Dr. Mussolino. And we went in, and here I thought I was doing everything I could for my son, and I learned a lot more about visual processing at that visit. So she shared with me that there's the mechanics of the eyesight, the 20/20, and then there's the visual processing. So my son entered kindergarten in September of this year. And as you can imagine with COVID, everything's been a little different this time around. But what she educated me on as a parent was there's a lot more to vision than just your 20/20. And as he's entering kindergarten, she stressed that the next 3 years of his development are going to be crucial and is to maximize his potential moving forward. So I learned a lot about Perkins and what Perkins can do to evaluate his abilities in that area. So fast forward to where I am today is I'm trying to navigate this kind of next phase of his life. So I'm learning about CVI, and that's what we'll be talking about today. I'm learning how to navigate the public school system in the US and how to advocate for my son because they wanted to just have the occupational therapist do a vision evaluation on him. And luckily, because of the knowledge I had gained with the pediatric stroke clinic, I was able to push for Perkins. And now Perkins is currently, I think, in their 3rd round of assessing his visual processing capabilities as it relates to his learning. So that is our story. I'm sure your stories could be similar, different, but that is Owen's vision history. So with that, I want to get to our main event. Our main speaker, Dr. Lofty Marabet, is with us today. He is an associate scientist with Massachusetts Eye and Ear, which is located right next to Mass General here in Boston. And he's an associate professor of ophthalmology at Harvard Medical School. So without further ado, I'd like to turn this over to Dr. Marabet to take us through CVI and the impact of visual processing on these little kids' brains.
Thank you, Gretchen. Good morning, everyone. I'm going to share my screen. Hopefully this will work. If Gretchen, maybe you can give me a thumbs up if this indeed is the screen. Excellent, wonderful, thank you. So good morning, everyone. Once again, my name is Lotfi Marabet. I'm a vision scientist at the Mass Eye and Ear and Harvard Medical School, and I'm particularly interested in understanding how the brain adapts to visual impairment, both related to eye causes of visual impairment, but also to brain-based causes of visual impairment, as Gretchen mentioned this morning. I was given a rather challenging task of trying to summarize the brain, the visual system, neuroplasticity, and CVI in about 30 minutes. So I've tried to put together some slides that hopefully will kind of put this all into context. And at the very end, I will finish with some ideas about neuroplasticity, how it relates to development, and hopefully that will be helpful, spark a discussion. And of course, I'm available to take any questions on the topic. So the first thing is that I have to get to my first slide, which is not cooperating. Here we go. Wonderful. So I remember when I was an intern, I had a supervisor who had this great quote, and he said, "Neurology is just like real estate. The 3 most important things are location, location, and location." And what he was referring to is this idea that there is a relationship between brain structure and brain function. In other words, the 2 go hand in hand. And more specifically, what we know today is that if you were to look at the overall surface of the brain, meaning the cortex, it all pretty much looks the same, right? There's nothing there to indicate that certain parts of the brain do certain things. And indeed today, over decades and decades of research, what we know is that the brain is highly specialized. We know that certain parts of the brain are responsible for seeing or vision, some parts for touch, some parts for memory, smell, and so on. And this is actually quite quite unique. And this is an extremely important property of the brain because, as I said, structure and function go together. That's to say that if we know what part of the brain is damaged, we should have a good idea of what type of deficits or impairments that patient has. And vice versa, if we know what type of impairments or deficits this person has, we should have a good idea where the damage is in the brain. So we constantly go back and forth between these two relationships of structure and function. I want to make just a couple of comments in terms of brain development, and I realize this is a very, very busy graph. Lots of data here, but I'm going to walk you through it because I think there's a lot of important takeaways. On this axis here, you see percentage change. In other words, the higher you are on the graph, the more change is actually happening. And on this axis here, you have age. So from 20 weeks to 35 weeks gestation to birth, 1, 2, all the way to 20 years in a lifetime. And then you have all these lines. And these lines represent change in various parameters of brain development. So gray matter is the overall volume of the brain, of the gray matter, the cortex. White matter connections are the connections of the brain inside. Surface area gives you a sense of how large overall the brain is. Fractional anisotropy is a measure of myelination, which is the insulation of brain cells. And cortical thickness is another sort of indication. The important takeaway from this figure is the following, is that the basic structural and functional framework of the brain is in place by the second year of life. After 2 years, brain development is essentially reorganization, fine-tuning, plasticity, and remolding, or remodeling, I should say, of established major circuits and networks. So the important thing to think about here is that by the age of 2, you are essentially born with all the brain machinery you're going to have. It's a numbers game at the very, very early stages of brain development. The other thing that you'll notice is that after that, all these parameters just seem to flatten, level off. And the only thing that really changes or increases over time is the connections of the brain. So once again, to reiterate that, by the age of 2, you essentially have all the machinery you're going to have. And then after that, it becomes a remodeling game, a wiring game, trying to put the brain and connecting it properly. The second thing to think about is that we have something what's referred to as the critical period. The critical period is the stage in which the brain is especially sensitive to environmental stimuli. And in humans, this corresponds to roughly between the ages of 2 and 7, right? So this is when the brain is particularly sensitive to change and responsive to environmental stimuli. It is indeed roughly between the ages 2 and 7, but another thing I want to make important is that this isn't a full stop. The door doesn't close at the age of 7. We know that plasticity and change occurs throughout life, but things get harder and harder as you get older. In other words, harder and harder in terms of inducing change as you get older and older. So I think this is a very, very important figure because, again, it shows you that the brain essentially changes strategies during development. Up to the age of 2, it's a numbers game. The brain is massively changing, creating proliferating cells inside the brain. And then after the age of 2, what we see is essentially remodeling and rewiring of the brain. And it's interesting because we all know that at the age of 2, we have these terrible 2 periods where the child is very, very rambunctious, a lot of activity, identity, and emotional things and so on. And it's kind of interesting that those terrible 2s seems to also correspond to this change in brain development strategy as well. So here is the term of neuroplasticity. I'm sure many of you have heard this, and I'm going to just share with you the definition that I typically use. It is the ability of the brain to change its structural and functional organization in response to development, experience, the environment, or damage. The important thing to think about is that it's not a guaranteed fix. It's not necessarily a good or a bad thing. It's the inevitable consequence of how the brain works throughout a lifetime. It's an intrinsic property of the brain. And I say this because in my clinical experience, I work with a lot of patients with brain injury or visual impairment and so on. And very often patients or families will tell me, when is the neuroplasticity going to kick in? When is, going to come, when's it going to happen and just make this all go away and get better? And unfortunately, it just doesn't work that way. It's not a switch that we just turn on and off and, and things will miraculously, get better. It is an intrinsic property of the brain. And our job as clinicians and scientists is to understand those parameters so we can guide and steer the brain in a way that can maximize these adaptive changes and compensatory behaviors. So it's an important thing to think about. In terms of the visual system, which is what I was asked to kind of concentrate on today, I was thinking about a way that to sort of propose this, or to give you sort of an analogy, a working analogy to think about. And you can think of the visual system as a digital camera. And if any of you have worked with a digital camera, you know that there's two important parts. The front of the camera is the lens, and this is the optics part of the camera, right? This is responsible for focusing, keeping that image nice and sharp, and also for allowing light to enter and controlling how much light enters the camera. The second part, the back of the camera, is the camera body. And this is the processing part of the camera, right? This is responsible for taking information in, synthesizing whatever that information that's coming in, and then when you close the shutter and you look at the back of the camera for a split second, there's a little delay, and then all of a sudden there's a nice picture. And if all things go well, that picture in the back of the camera should correspond to the image that you're looking at. The visual system is very, very much broken down in the same way. The eye is very much the optic system. In fact, you look closely, they look very, very similar in terms of design. The eye is letting light in and is focusing, and then sending that information to the back of the brain, or to the cerebrum. And when I say the cerebrum, I'm talking about the entire brain. And this is the processing part of the brain. So taking that information in, synthesizing it, and generating the image that you're looking at. So just to show you a nice little image here to give you a sense of the pathways, this is a three-dimensional representation here. You see the two eyes in the front, and you can see how information leaves the eyes, goes deep into the brain, what we call the thalamus or subcortical structures, and then that information is sent to the back of the brain where the processing actually occurs. I like this figure here because you can see right here in the middle, this is the chiasm. You see how information crosses, right, and then enters the back of the brain. And this is important because we know that the left side of the visual world is controlled or is processed by the right hemisphere or the right side of the brain, and vice versa. So the information crosses and enters the visual cortex, and there's a corresponding crossover in terms of how information is processed. So going more into detail. So as I mentioned, information starts, or the image is focused onto the back of the eye, right? That's the first step of visual processing. And you all know that if for whatever reason, that image doesn't focus properly in the back, if you're nearsighted or farsighted, we give glasses to make sure that that image focuses as sharply as possible onto the back of the eye. Once that image reaches there, it then enters the brain, as I mentioned, into these subcortical structures, and then to the back of the brain, the occipital visual cortex, where the processing begins. Once we're in the cortex, that's really, like I said, where the processing happens. And the important thing to think about is that once that information or that image gets in, the first thing the visual brain does is break it down. So the very first step of visual processing, what's called V1 or visual area 1, is essentially a rough sketch pad of the image that you're looking at. V2 is the two images of the eyes fused together, and that's how we have depth. That's how we can perceive information in 3 dimensions. And then as you march up the visual system, different aspects are broken down or specialized by different areas. So form, or the overall shape of an object, is processed in what's called area V3. Color is processed in area V4. The actual motion of an object is processed in area V5. And we have areas, for example, responsible simply for the perception of faces, or recognizing, I should say, of faces, which is called face fusiform area. And we go up and up and up. This doesn't correspond to where they are in the brain, but I just want to demonstrate to you that all these areas are interconnected and have to work properly in order for you to perceive the visual world. And today, neuroscience tells us there's about 30 areas that are separate areas that are involved with processing a visual scene, specializing and scrutinizing and analyzing different aspects of the visual scene that are integrated in order for us to perceive the visual world. So the other thing to think about is, despite the fact that we have this image that is broken down and has to come back together again, there is an overall organization that the brain follows in terms of how it perceives the visual world, what we call the dorsal and ventral processing stream. We know that visual areas from the back of the visual brain to the top of the brain here in the parietal cortex and to the front, called the frontal cortex, is what's referred to as the WARE system. This is a system that is essentially interested in terms of figuring out where things are in the visual world, right? Spatial processing. In contrast, we know that information or visual areas that line up from the back of the visual cortex down the temporal lobe are referred to as what's called the WHAT system, and this is more involved with object processing. So in other words, what an object is handled by one stream of the visual processing pathway, and where that object is processed by a parallel stream called the dorsal stream. And it's important to keep in mind that even though we functionally divide these two streams, these two streams have to interact, right? They have to work in parallel and in unison. And more evidence now is showing that these two streams, while from an organizational standpoint may seem parallel and independent, but in reality, they communicate quite extensively. All right, so let me sort of give you a sense of why I think this idea of integration is extremely important. And I need to actually volunteer for this one. Gretchen, are you still online?
Yes, I am.
Excellent. Okay, you're going to help me on this demonstration here. Are you ready? You have not seen this before, right?
That is correct.
Excellent. Very good. So here's a very simple task. I'm going to show you a picture. Your job is to find this blue O. Are you ready? You just tell me when you see it. Ready? Here we go.
I see it.
Yeah, very easy, right? Here it is. Very simple. Give you another one. Here we go. Find the blue O. Are you ready?
Yes.
Here we go.
Got it.
Yeah, very simple. Right here. Yeah, really easy. We're gonna do this one more time. Are you ready? Find the blue O. Tick, 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 tick. Got it? Yeah, a little bit harder, isn't it? Yeah.
I see it.
You got it now? Yeah. In fact, there's actually two of them, right? So why was there a delay? Why was it so easy for the first two? And then all of a sudden the third one, things got a lot harder. So thank you for participating, Gretchen. I'm going to try to explain what actually happened in this little demonstration. When the object or the target that you were looking for was different only because of its shape, basically your form area of the brain was the one who was actually making the decision. When I then asked you to try to find the target based solely on color, your color area was the part of the brain making the decision. But when I put the two together, these two areas have to work together. They have to talk to one another and get on the same page. And that takes integration, right? And that takes time. And that's exactly what I mean by processing. So you can imagine with this very simple demonstration here that the two properties coming together, when you open your eyes and you look at a very complex world where there's lots of color, lots of things moving around, things moving, overlapping on one another, it's really, you can appreciate how the processing part is extremely important in terms of synthesizing and creating the overall image that you're looking at. The last thing I want to mention before we get into the actual discussion of CVI is that along with the processing comes this very important piece, which is eye movements. Eye movements tell us something about what is going on and how you are perceiving the actual visual world. It's quite easy to do. We use something called the Tobii eye tracker. This is something that you can connect on the bottom, I should say, of a computer monitor and tracks your eyes as you move around and search a visual screen. Even in pediatric populations, this works quite well. So again, the reason why we do this is, one, it tells us something about how you are perceiving the visual world. Where the eyes move is very telling in terms of what your overall thought process is, if you will. The other thing we know is that when we study eye movements, we're studying multiple levels and multiple areas of the brain. It's not just the eyes moving, it's also deep structures in the brain that control those eye movements. It's the visual cortex, it's higher order areas along the dorsal and ventral stream. It is frontal areas involved with attention and focus. So when we study eye movements, we're essentially taxing a lot of brain areas and gives us a sense of overall integrity of how the brain is functioning. This was a classic study by a guy named Yarbus, who was one of the very first individuals or scientists to demonstrate how eye movements reflect overall thought processes. And what he did is a very simple study like this, where he has a picture of an individual entering a room with other individuals. And he just simply asked individuals to freely explore the visual scene. And this may look completely chaotic, but there is a method in the madness. And what you see is the eye movements are essentially concentrated on things that are the most meaningful, like the faces of the individuals, objects on the table, objects on the wall, right? The eye movements are not random and just looking at everything on the screen. They are generally directed to things that probably will give us the most information about what we're looking at. The other interesting thing about this is that in the next task, he said, okay, I want you to look at the same picture, but now I want you to tell me what is the overall wealth, the material wealth of the individuals in the room. And what do you notice? Now the eye movements are more concentrated on what the people are wearing, not their faces and the objects, because at that time, certainly the way that you dressed was very much tied to your overall wealth. So the point I'm trying to make is that eye movements reflect your thought process. Eye movements tell us what you're looking at, what you're interested in, what you're paying attention to. And it is a very good proxy of overall how the visual system is working. So with that in mind, let's switch now to the last part here, which is overall discussing about CVI, or cerebral visual impairment. And just to give you a little bit of background, this will give us some background in terms of why this condition has become extremely common, and why we're very, very concerned about moving forward, and how, given the visual processing systems that we talked about, what happens when we have damage to the actual visual processing systems. So this is the Perkins School for the Blind. Some of you may know it's located just outside of Boston. It's the first and the oldest school for the blind in the country. It has a very, very long, illustrious history. If you were to look, say, 50, 60 years ago at the classic sort of child who was enrolled at Perkins, you would find kids who were blind or visually impaired due to problems at the level of the eye. So it could have been infections like rubella, for example. As time went on, that sort of changed. You know, a lot of the kids were blind for things like retinopathy of prematurity. There were some children that had various genetic disorders and damage to the eye as well. Then about 20, 30 years ago, something changed. The profile, if you will, of the classic Perkins kid changed considerably. And what they found is more and more kids were enrolled at Perkins who were visually impaired, not because of necessarily problems of what was happening at the level of the eye, but rather problems at the level of their visual brain. And they were also presenting with other issues as well, motor issues, other sensory impairments as well, cognitive impairments also. So the profile changed dramatically. And this is extremely important, because what we knew is tried and true for children with ocular-based visual impairment and blindness didn't seem to be working as well for these kids. And the question is why? How is it that you have two children, both with, say, 20/80 visual acuity, one because of eye-based causes and the other because of brain-based causes? Why are they so different, even though they may present with a similar level of, quote, visual impairment? So you might be surprised to realize that if you look at all the kids who are enrolled at schools for the blind across the country, and you rank order the diagnoses that's associated with their visual impairment, you might be surprised to find that the number one diagnosis of children enrolled for schools in the United States, so schools for the blind in the United States, is cortical or cerebral visual impairment, CVI. So all the other causes that you see on this list, things like infections, like syphilis, herpes, rubella, these are all going to decrease with time as we have better and better public health programs and immunizations, infection control, and so on. Things like retinitis pigmentosa, Leber's, and so on, these are genetic disorders. And with a lot of progress that we're making in gene therapy, for example, you would also think that these numbers are going to continue to decrease. This is retinopathy of prematurity. Turns out we did this, and now we have much better control in terms of neonatal care. So we know that these rates are also decreasing over time. So what I'm proposing to you is that cortical or cerebral visual impairment over the future, over a long time horizon, is going to be really, really the big driver. So what it means to be born blind or visually impaired in the future is going to look very, very different than the way that it's looked historically. And we have to be prepared for that. So you might ask yourself, why is CVI the number one cause of pediatric visual impairment and blindness? How did this happen, right? I remember when I was going through school, we didn't even talk about CVI. And the answer is that the majority of these children are somehow associated with some sort of perinatal injury or complication around birth. And the reality is also, we're getting very, very good at saving these children. These children weren't surviving 20, 30, 40 years ago, but they're surviving today. They're thriving, they're living longer, and we need strategies of assessing these visual impairments and their other issues as well, and creating environments for them to thrive and to do well. So again, just to leave you, rather not to leave you, just to drive home this point, the number one individual cause of pediatric blindness and visual impairment is not disease of the eye, but rather damage to the brain. And I think this is a very, very important point to keep in mind, because that's fundamentally changing our perspective about being born with visual impairment. So a little bit more information about CVI. So cerebral, also called cortical, also brain-based visual impairment, is defined as abnormal visual function despite, quote, a normal eye examination. So this was an old definition, and I don't think it's exactly correct. And the reality is, because many children with CVI also have eye-based problems. They could have an eye turn, they could have various structural issues with the eye as well. So there is a more recent definition that came out in 2017 that I think really, hones in a little bit better. And it says it is significant and verifiable visual dysfunction associated with damage to retrochiasmal pathways. Remember, the chiasm leads to the back of the brain where the information is sent to the brain, and cerebral structures that cannot be attributed to disorders of anterior visual pathways or potential co-occurring ocular pathology. In other words, it is visual impairment that is largely brain-based as opposed to eye-based. In other words, it's a processing problem, not an optical problem, or largely a processing problem as opposed to optical. We know that visual acuity can range from normal to profound blindness. We see the total gamut in these kids. Visual field deficits are typically in the inferior visual field. Some show reduced contrast sensitivity. Some have ocular motor disorders as well that we can characterize. So they have a lot of issues going on in terms of their visual function. There's also, and this is a key thing, a medical history that is consistent with pre or perinatal neurological impairment or injury, right? This could be cerebral palsy, this could be epilepsy, and there are characteristic neuroradiological findings, which I'm going to show you in a couple of minutes. The take-home message here is that when it comes to diagnosing CVI, history matters. What happened at birth, shortly before, shortly thereafter, is extremely important, because that is what's going to raise the suspicion that what that child's visual impairment is associated with is largely more a processing or brain-based issue as opposed to eye or ocular based issue. The last thing I'll mention in terms of CVI, which is extremely important and really, again, differentiates this compared to children with ocular-based visual impairment, is often there is the presence of unique higher order visual processing deficits, things like visual spatial or complex motion processing. And overall, there's this term that's been coined with this, is what's referred to as dorsal stream dysfunction. In other words, it's largely associated with processing along the dorsal stream that I had mentioned earlier. So let me give you just a couple of examples to drive this point home. Many children, for example, will tell us that when they're walking in an environment, they have a very, very hard time perceiving things that are moving, and especially if they're moving themselves. So they'll be walking down a corridor, for example, or in a car, and they won't recognize the various exits that the car will take, for example. Younger children, they can look at their favorite toy and say, yeah, that's my favorite toy. But if I put it in a toy box, they can't find the toy anymore. And we call these children dumpers. They take their toy boxes and they have to dump them out and sort all the toys out individually in order to find their favorite toy. Again, this isn't an acuity problem because they can identify the toy in isolation, but they can't identify it in a large cluster of items. Older or adolescent children will tell us that in high school, for example, if they walk down a corridor, they'll miss their classroom, they'll walk right by their teacher or a friend and just simply not recognize them in a crowded environment. Dr. Barry Cran, who's the director of the Perkins Eye Clinic at the Perkins School for the Blind, has a great analogy, and he talks about is that every child is very, very unique in terms of their presentation, and he thinks it's like a slot machine where each tumbler could be an actual property. The first wheel could be their visual acuity, their second could be their contrast, their third could be their attentional issues, and then you sort of pull the lever, and however the combination comes up, that's the unique presentation of that particular child. So I think a useful analogy to understand the tremendous variability that we see in children with CVI. Very, very quickly, the causes of CVI, there are many. The most common, as I mentioned, is some sort of perinatal hypoxic or ischemic event, right? Some stroke or vascular event that occurred just before birth or shortly thereafter. There are many other causes worth mentioning as well. There are maternal health issues, pregnancy complications, head injury, trauma, infections can also be involved. More and more now we're seeing children with genetic and metabolic disorders also being associated with CVI. So many, many causes that are associated with this condition that also make it incredibly challenging from a diagnosis and therapy standpoint also. Just a couple of comments. Going back to the perinatal hypoxic ischemic issue, we know that there are extensive changes throughout the brain that are caused because of this brain injury. But one of the most common and interesting things is the effects on white matter. White matter, as you'll remember I mentioned at the beginning, is how the brain is connected, how the brain is wired. So we know that these brain injuries affect the cortex, they affect deep structures, but in particular, they affect how the brain talks to itself, the actual white matter connections. So very, very briefly, in children who are born premature, that's before 32 weeks, we often see CVI associated with periventricular leukomalacia. These are these enlarged ventricles that we see in the brain, and around the ventricles are these white matter connections that we know become damaged because of this hypoxic event. In children who are born term, we call this hypoxic ischemic encephalopathy, or HIE. Different in terms of mechanism, and in terms of how the brain is damaged, but overall very similar in terms of the extensive overall injury to the brain, deep structures, white matter, as I mentioned, and as well the cortex. So let's move to just a sample here to kind of, again, drive home the challenges of brain imaging and diagnosing CVI. What I'm showing you here on the left, this is an axial cut through the brain. This is a standard MRI image of a sighted control who has 20/20 vision. This person here is profoundly blind, right? Has light perception, right? Due to ocular blindness. And you'll notice that the two brains look very, very similar, right? I challenge you to tell me who is the one who is sighted and the person who isn't. And the third brain that I'm showing you here, you can see these very, very large ventricles, as I mentioned, periventricular leukomalacia, hallmark sign, especially in children who are born premature, which clearly has extensive brain injury or brain restructuring, but this individual is 20/20, right? So the take home message here is, how do you have two individuals whose brain looked identical? One is profoundly blind and the other one isn't. This individual whose brain is fundamentally structurally different, but yet they're 20/20. And then this drives home the point, or what's referred to as the neuroradiology paradox. In other words, apparent damage or lesion load doesn't always correspond to what that individual is going through in terms of their symptoms and their actual deficits. So trying to create the structure function relationship is very, very difficult, particularly in the case of CVI, because we don't have all the information to help us understand. So the take home message here is that we think that CVI is a disorder of brain connectivity. It's a brain wiring issue. And the underlying connectivity is associated with observed visual dysfunctions or impairments. So what we need to do is not just look at the overall structure of the brain, we need to look at how the brain is wired. And to do that, we use a technique called high angular resolution diffusion imaging, or HARDI. This tracks water movement, the movement of water molecules inside the brain. And when the computer detects water, or the scanner detects, I should say, water movement in a particular plane, in a particular direction, it can associate that with the orientation of an axon of a nerve cell. And through very fancy algorithms, it is able to take that information and recreate and reconstruct in 3 dimensions the overall wiring pattern of the brain. So this is what you're seeing here. On the left is a control individual. On the right is an individual with CVI. I'm going to play this video here. You're going to rotate in 3 dimensions, right? This is the outside of the brain. You're now looking at the connections inside the brain. And on this pass here, what we do is we ask the computer to simply show us the connections of the visual cortex to the rest of the brain, right? Virtually dissect away the other connections. Tell us what the visual cortex here in the back is connected to. And in the control individual, what you see, sorry, I played twice. What you see here is that the dorsal stream from the back of the visual brain to the top of the dorsal, the parietal cortex to the frontal cortex corresponds to the dorsal stream, right? This is the pathway responsible for spatial processing. The ventral stream that we see here from the occipital cortex down to temporal cortex corresponds to the what pathway for object recognition. Very, very nice, very, very well-developed arborization and patterns here. But in the CVI individual, what do we see? The ventral stream seems to be developed, not as well developed as we see in the case of the control individual, but the dorsal stream is clearly impaired in terms of its development, which again kind of fits with this original hypothesis that this is a dorsal stream related impairment. That's not to say that ventral stream impairments don't exist, but it really seems to drive home this idea that the anatomy, the wiring of the brain in terms of deficit, fits with this presentation of dorsal stream related dysfunction. Last thing I'm going to share with you is how we assess visual function in these kids. And we go beyond just simply, standard eye tests like acuity and contrast and perimetry. We need to go further and have a better understanding of how that patient sees and how they use their vision in the visual world. If you work with kids, trust me, dots, stars, and letters are boring. We hear this all the time. They simply just don't want to look at boring letters on an eye chart. They want to be able to look at things that really make more sense and that correspond to their visual world, like, for example, finding their favorite toy in a toy box. The challenge with this situation is that when we study, for example, or assess visual function, meaning, acuity, contrast, things like that, these are very, very well-controlled stimuli, but they don't reflect the overall real world, what we call ecological validity. The real world, by definition, is obviously ecologically valid, but we can't really assess performance in that world either because there's so many things going on. The lighting, every world is different. It's hard to control for the actual stimulus features. So we need a middle ground. And we think that middle ground is virtual reality, where we can control the stimulus in terms of the parameters and what's being manipulated, but at the same time, we can create environments that are highly ecologically valid and reflect the real world. So one of the tasks that we developed is something called the virtual toy box, right? So in this particular task, quite simple, the child sits in front of a screen. The eye tracker, as I mentioned, is on the bottom here, and the child has to pick their favorite toy. It could be a yellow duck, a blue truck, in this particular case, an orange basketball. The point is that we do this so that the child can identify the target in isolation and also feel very, very engaged to participate in the task as well. And then there are 3 levels of difficulty. The toy could be placed anywhere in this 5x5 matrix, right? So it's like you're looking down into the toy box, and we change the number of distractor elements or unique distractor elements in the toy box. And our theory is that as we change the number of distractor elements, the task should get harder. There are more and more things that the child has to ignore in order to try to figure out where the right target is. We also throw in something called a color match. A color match is a second toy that has the same color, but obviously not shaped the same, because we want to know what is the cue the child is using in order to try to identify the target. And we also have a maximum clutter situation where we put a very, very busy visual scene in the background to see how is that child sensitive to overall clutter. And this is what the data looks like when you do this. So I'm showing you in this video here, a control is on the left, a CVI individual is on the right, age matched. This yellow blob that you see in the middle is where the eyes are looking at any given time. We don't normally show this during the task. I'm just showing you here for the demonstration of where the eyes are looking. So let's just play this head-to-head comparison. And what you should see is right away, do you notice how the movements of the CVI individual are much more sort of circuitous before they actually get to the target, right? They get there, but they're not anywhere as quickly. Here's the color match. You see how the CVI individual has to check both in order before they make the decision of which one it is, right? And here's the situation with the background clutter. And this particular situation, the CVI subject missed it completely. So the takeaway message here is that in terms of CVI, they're very, very sensitive to environmental clutter and distractions. They can get and find the target eventually, but it's a much more circuitous, much more complicated path. This also fits with the clinical presentation because a lot of these kids tell us that at the end of a school day, they're exhausted, right? They're absolutely exhausted because their eyes are working so much harder to try to carry out the task in question. We could put also this to numbers. What I'm showing you here on this graph is worsening performance, right? So as we go up this graph, the worse the performance is. As we go down this side here to the right, this is the task difficulty. So the more we move to the right, the harder the task is. So from low, medium to high. And what we find here in our controls is you notice how the relationship is pretty much flat. So from low, medium to high, the relationship to task demand, slight uptick from medium to high, but is essentially flat. In our individuals who are ocular visually impaired, so individuals, for example, with retinopathy of prematurity or ocular albinism, we see also this very, very similar relationship, largely flat, but just raised to a higher level. And in our kids with CVI, they start off somewhere in between. And as the task gets harder, we see this steep relationship here with task demand. In other words, they are extremely sensitive to increasing task demands. And we don't see this in our controls, and we don't see this in our ocular visually impaired kids as well. The second thing I'm going to mention is that we have a subgroup of individuals with CVI who have very, very good visual acuity, 20/20, 20/25 visual acuity, and their performance on this is exactly the same. Their curve looks exactly lined up with this one. So high visual acuity doesn't get you out of this situation, right? So it's really a processing problem. It's not necessarily an optical or eye-based problem. All right, so just to wrap up, a couple of comments in terms of the laws of plasticity and some comments that hopefully that are helpful for, especially for the parents out there on the call this morning. The laws of plasticity are the following. Plasticity is a fact of life. As I mentioned, it's not necessarily a good or a bad thing. It's an intrinsic property of how the brain works. It can be compensatory, it can be adaptive, there's no question, but it can also be maladaptive. There are situations, for example, where the brain rewires itself in a way that doesn't help the overall development or functioning of an individual. Second thing to think, or next thing to think about, is that timing matters, right? An injury that occurs when you're 20 years old or 60 years old is very, very different with the same injury occurred shortly around the period of birth. So the timing of the injury is extremely important. And you saw that graph that I started off with. Where the injury happens will often cause a cascade of repercussions that are important to consider. And this obviously has impacts for the habilitation or rehabilitation of the patient. You use all your brain all the time. It's not 10 or 15% as you may hear in some cocktail parties and so on. You use all your brain all the time. And the key, as I mentioned, is to figure out how do we guide neuroplasticity in a manner that is really the most beneficial and compensatory for that individual from a rehabilitative standpoint. How can we enhance plasticity and brain development? There are really sort of four sort of guidelines that I think are important to consider. The first is really love learning. This isn't just in the case of CVI, but I think this is important from a developmental standpoint as well. Really establish this growth mindset, promote discovery. I think as parents in particular, we're really focused on results. And I think we really should think about the process. And this is particularly true at younger ages and during brain development. The brain likes to explore. The brain likes to be challenged. And the more that we can kind of think about and challenge the brain is extremely important. Understand that there needs to be a balance between repetition and novelty. If you want to remember a phone number, for example, you tend to repeat it and repeat it and repeat it until you remember. But at some point, what we know is that repetition also becomes boring. So we need new ways to kind of stimulate the brain and keep it engaged. So finding that balance between repetition and novelty is extremely important. Second thing is what I call buffet style learning. Think about breadth over depth of skill development. Again, the classic example is if you have a young adolescent who's a gifted athlete, they tend to, for example, just concentrate on that sport and spend all their time learning that particular sport. What I would argue, particularly at younger ages, is that, being very much more of a jack of all trades, playing lots of different sports and activities, doing very, very different things is very good from a brain developmental standpoint, because those skills will cross over and support one another. So I think it's important to stimulate and promote this idea of cross training, if you will. Third thing I would say is emotional learning. The emotional brain, deep inside the brain, is an older developmental aspect of the brain. And I think it's extremely important to keep that part of the brain developed as much as the rest of the brain from a rational thought standpoint. So rationalizing and understanding our emotions is extremely important as well, because that all kind of comes together, as I said, with this brain connectivity standpoint. So keeping the entire brain and all its functions together in unison is extremely important. Then the last thing I'll say is get busy. And I say this because, when I talk to parents, especially in the case of children who are visually impaired or brain injury, they always ask me, what's the first thing I should buy, for my parents, or I should say for my child. And I say, get a Nike t-shirt, just do it. Get out there, engage with the world as much as possible. We know that there's a lot of scientific evidence that really drives home the point and the benefits of environmental enrichment. We know that developing the inner mind, that's essentially really what brain development is. It's developing an inner model that corresponds to the outside world and how we interact with it. So the more that we can do to develop that inner mind for the child so that it makes sense, so that it can make predictions, so it can actually interact with it, the better. So set up for success, create safe learning spaces, have that child understand that it's okay to make mistakes, but at the same time, driving these ideas of explore, try new things, also understanding that success comes with effort, I think are all very, very important skills. And the last thing I'll mention here is that remember that it's not over after the critical period. That certainly is that period of time where the brain is the most sensitive. But I think it's extremely important to think about that the brain is constantly changing throughout a lifetime. Things might be harder. It's a
What happened?
Lotfi, maybe he froze. Looks like he froze. So we're gonna try to see if he comes back. Yeah,
Cinnamon.
he dropped off. So first, I want to thank everyone for coming and listening today. There are lots of questions about recordings, and we are working to set up either a YouTube channel or a website or a combination of those things so that we can share recordings in the future. And we will let everyone know who's registered, and I'll also be posting on the various social media channels where I've been posting to share the recordings once they're available. I think he may have dropped off.
I am back. I apologize for that. When did I drop off? Just out of curiosity.
Just in the last slide about neuroplasticity, but we're going to shift to take some questions now.
I apologize for that.
And I actually want to start with this question from Flora. Flora, are you there? Would you be comfortable to ask your question?
Yeah, sure. My daughter, she had a stroke when she was 2. Mm-hmm. She's now 12. Mm-hmm. Sorry, 13. So she has auditory processing issue, but from what you described, I do think she has visual processing issue too. Mm-hmm. Because but then we do a lot of alternative treatment, try to train her brain, as you said, neuroplasticity. So we do see her brain change, but the big problem for her is whenever we try to train her, then it triggers her seizure. So I don't know why is it. And yeah, we already do a lot of nutritionists and everything to support her brain at the same time. Right. But still, like this morning, she had 2 big seizures. I don't know why, but
right. Yeah. So thank you, Flora, for that question. That's an excellent one. And it's unfortunately something that we see quite a bit. Seizures, you can think from, quote, a pathological standpoint is again, reflects brain wiring, right? It is activity that is happening when it shouldn't, right? You can think of it almost as like an electrical storm or a brain activity that is out of control, so to speak. It's not entirely surprising because when that child is engaged in various tasks, the brain is more active, and therefore it may hit a certain threshold where that brain activity becomes aberrant and triggers a seizure. So I certainly can understand from a pathophysiological standpoint why that happens. What we do know from neurology and pediatric development is that it's extremely important to control those seizures first. Right. So I think if that is happening, we know that uncontrolled seizures for that child overall is very, very detrimental. So it's extremely important to control the seizures. That takes a lot of titration in terms of the medication, the dosaging, when they take it, understanding what could be trigger features for those seizures as well. So there has to be a lot of groundwork done initially to control the seizures. And once they're under control, then that child can kind of move into the phase of more sort of rehabilitative aspects and so on, because you don't want to be in the situation where you're going back and forth, where the child is making, great progress, skill development, still having these seizures. You then have to go and kind of control the brain, and then that child sort of regresses and kind of ping-ponging back between these two situations. So my suggestion in this particular case, it sounds like, again, I'm excited to hear that you have these ideas to try different things and so on. I think that's a good thing. But I would say the first step to establish is to control the seizures, and then from there move on to next steps.
Thank you very much.
Yeah. Best of luck.
Great. Thanks. Can Francesca, can you come on and ask your question about learning?
Yes, sure. Thanks for inviting me. I'm from Italy. I'm very excited to be here because it's very interesting. Also, the way you speak, it's very understandable.
Thank you.
So my question was more general on children with perinatal stroke. How does it come that most of them also have learning issues? So is the visual part implied on this? How, especially on reading, I would say.
Yeah, so great question. I'm not sure if Patty's on board as well.
I
think
am.
Wonderful. So I'll say a couple of comments, and Patty, I'll ask you to jump in as well. This is certainly well in your wheelhouse. So I think certainly to that question, vision does play extremely an important role when it comes to learning. You think of vision for reading, you think of vision also to pick up on social cues, how other individuals. We know this is extremely important from our work with children who are ocular blind as well. And, how do we teach those concepts? Many concepts, for example, are uniquely visual. Color, for example, is something that is really uniquely visual. So how do we train, or how do we learn these concepts when we don't have, quote, the benefit of visual information? So that's the first thing I would mention. The second thing, and I think Patty's going to be really in the right position to comment on this, is the extent, the location, and the timing of the injury may be so crucial in terms of the areas that are hit. Could be language areas, it could be parts of the area, again, responsible for perception, that injury then sort of creates a knock-on effect or a domino effect to those other areas that will then hopefully come online with time. But I'm going to hand it over to Patty to maybe comment specifically on language and motor issues as well, and learning issues, I should say.
Thank you, Lotfi, and thank you for the question, Francesca. I think the point is every kid is very unique, and this is the part that I always want parents and providers and everybody to talk about. Where is the lesion? And every time you see them, even if it's once a year, could you tell me again what part of the brain the lesion affected? Because it is empowering to kind of understand those areas. And I want to say something about specifically perinatal stroke, which is not the same for a kid that has a stroke after 6 months of age. If the stroke happened at that very critical time of development, the areas, even though the brain kind of, as it knew it, was going to map things in those areas, language and the vision and the pathways, and the most common strokes, which are MCA, middle cerebral artery strokes, do affect directly those pathways that connect the eye, as you guys saw today, with the cortex. And the cortex, the visual cortex, with all these other functions that Lotfi is saying, that we need to even learn how to move our lips, because we do it by imitation. And you work on this specifically, so you know very well what I'm talking about. So even mirroring, which is the first function in a baby, it's using visual information. And these networks are being always used. But one important thing is, if you can understand a little bit where these lesions are, in a baby, the functions may end up being mapped somewhere else, in the contralateral hemisphere, in other areas surrounding the lesion, or in surviving neurons that did not get knocked down during the lesion. And that happens all the time. So what am I trying to say is, in a perinatal stroke, it really, the difference is in how we provide the environment. And I love the bullets that Lotfi provided about how can we do this. And it's really the experiential part, because to develop any function, and you guys can watch your babies, they're not using one domain. They're not using tactile, they're not using only vision, they're not only using sound, they are experiencing the world. So variation, allowing them to experience. And if you don't know what to do, just leave them in the floor. That's the best way to literally let them not have to deal with gravity and be able to really move. And you can just watch them and try to support that process. That changes completely that learning capacity. And their learning disabilities or challenges, I wouldn't call it, I don't know, disabilities to me sounds sometimes not accurate as a term. The challenges in learning need to be addressed by us, the school, the providers, the therapists, the parents, even the siblings. Because if we understand, okay, well, it's having trouble with visual spatial stuff, and it cannot make sense of the distance, but we can change that. We can help with that. We can get really close and say, is this too close? And help them develop that skill, because they really are a powerhouse of plasticity. In stroke later on, same concept applies. The difficulties and the challenges tend to be a little bit more difficult to overcome. But definitely the best way to do it is by this multimodal, experiential, very variable. So we don't need toys that have lights and they always the same color and the same tone, and the kid is touching, sitting in a chair. That's exactly the opposite of neuroplasticity. So it is entertaining, and we might have to do it if you have to go to the bathroom. But the point is, just that's not necessarily how the brain is supposed to be learning. And if we want the brain to learn, and if you watch a kid, if you leave them on the floor, they find all kinds of things that they are exploring and trying to make sense of it. And you can accompany this with very calm voice and trying to sometimes give a little bit of denomination for things that they may not be able to do themselves. And there is a lot of specific therapies that we can talk about. And in fact, I take the lead to say also that this talk continues with those kind of things. We're gonna have the therapist tell us what can you be doing and how can you be working with the kid to enhance that learning and decrease those difficulties.
Thanks a lot.
So we're actually at the top of the hour, and I know we haven't gotten to all the questions, and there also are people asking for the end of Lotfi's presentation because it got cut off. So I'll defer to you, Lotfi and Patty, about whether we can go over a little bit or if we want to close it out now. What do you think, Patty?
In favor for all of you guys that can stay to go a little bit over, and the reason is Lotfi can.
Yeah,
is
absolutely.
That we are recording this. So if you have to go, just go, and we will make sure that we also address the questions through the email and put them also on the website that we are developing. So I will favor continuing and then trying to address as many questions as we can, and then wrap up at some point. And Mara, you can tell us when to stop.
Okay. Erica, can you come on and ask your question about teenagers?
Yes. Hi. Good morning. Thank you so much for this presentation. I was wondering if you could speak to the pros and cons of computer gaming for teenagers.
Yeah, I get that a lot. In fact, a lot of the work that we were doing before this particular CVI subject was based on computer gaming. We were developing non-visual computer games for blind children, ocular blind children. There are definitely pros and cons, just like any piece of technology. Often it starts off with the right intent and there's a lot of positive, and then all of a sudden, kids in particular are very, very smart, and they figure out, that, oh, I can do this for other things, and things often can get out of hand. I will say there is tremendous positivity, if you will, when it comes to gaming, because what we know from gaming is that it teaches us, or I should say, it forces us to learn in ways that are not traditional. I think that is really the important thing. Game designers know this, right? They incorporate design features in a game like rewards. There are time constraints. Maybe if you don't do this, your avatar dies, for example. Very, very deep emotional feelings. They're very engaging from an intentional standpoint. So again, good game designers know to put in features that the brain is going to respond to and really keep the child engaged. So I think there's an opportunity here to tap into that in a way that could be beneficial for learning, skill acquisition, et cetera, et cetera. There's no question in my mind. But just like anything else, it can go overboard and then put that child or lock that child into a mode of doing things that doesn't allow them, again, as Patty said, to go into other modalities and other things and so on. So I guess the take-home message here is, like anything else, it's balance. I think, creating that breadth is extremely important, learning one way and in one modality and exploring other things, but it doesn't mean necessarily that one thing should go completely deep, so that child goes down a path that they can't come back to and think about other ways of thinking as well. So I would say incorporate gaming. I think that's a good thing, but not to the point where that's the only thing the child is doing.
And I would add games that can be played in groups to also build community. And in these days with our restrictions currently, that may be the only way that these kids are currently communicating and entertaining. So maybe the screen time that we want to say they don't exceed this number of hours, you may want to adapt that and encourage the type of gaming that is engaging a community of other teenagers and other people to work together. And there is research going on right now, and we collaborate with Northeastern University and Danielle Levac with artificial environment as a learning and trying to understand how this could help in the rehab. So how can we design games that also will go the extra mile to help kids with brain injury in a more specific way?
Danielle is actually on this call. So Danielle, can you come on and add to that and then also ask your question?
Sure. Yes. Thank you, Patty. Thank you for this wonderful presentation. So as Patty mentioned, I'm a physical therapist by background, and I run a virtual reality research lab at Northeastern. And so one of the things we're interested in is this idea of complex environments, right? And where's that line between too much stimuli and not enough, and how we can use these safe, ecologically valid virtual reality environments to train the brain or to provide stimuli that might not otherwise be available. So there's lots of questions asked there, and you alluded to some of that, Dr. Marabet, in your presentation when you talked about the benefits of environment enrichment. So my question was, do we know anything about this idea of richness or complexity or variation in the visual environment, particularly in the early stages? Do we have any evidence to show that that might impact things?
Yeah, absolutely. I don't know if I can share my screen again. I do have a slide where we've been dabbling a little bit. This has been developed by Chris Bennett in our lab, where we're trying to think about ways of using the virtual environments. In this particular case, for example, we can use the toy box task to think about cues that could be useful. You know, there's a lot of extensive neuroscience research looking at visual perception and what cues promote saliency. Some are stronger than others, and they could also be very, very individualized. So changing the lighting or the luminance of the target, you know, adding motion, changing color. So we can certainly probe on an individual level what cues would be most beneficial, you know, for that particular individual. And there's some work that we've done specifically on that. Another thing you can do, and again, this is Chris's work, where you can create this game-like strategy. Again, we don't really have strategies per se on how to incorporate this from a therapeutic standpoint, but Danielle, I'm sure, as you know, it's not difficult, I should say, to incorporate gamification into your strategy. So, for example, if the child looks at the wrong target, the score can go down. If they go to the right target and fixate, your score goes up. And again, as Patty said, doing this as groups and comparing to one another might be ways to kind of promote that engagement. The other thing I will also say is that virtual reality, like you, I'm a big believer. I think it's extremely powerful, but there's also something to be said for getting out there, right? Games with social interactions, the playground in the real world and so on are extremely important. We shouldn't neglect that also. So again, it's a question of balance. I understand, obviously, in the current times, we have to be a lot more creative. But again, at the end of the day, I think that buffet style learning, especially in the early stages, really leveraging the benefits of all these strategies as much as possible are I think, incredibly beneficial from not only from a brain development standpoint, but also on the path to recovery as well.
Hillary Devlin, are you still there? If not, is Tina Pembroke still on?
I am. Hi.
Yeah.
Thank you so much for doing this. I really appreciate this, this whole experience. But my question is, my son is now 14. He had an in utero stroke. It was a massive stroke on the outer part of the left side of his brain. And you know, when he's young, I felt like I was racing a clock, trying to do every type of therapy, every type of thing to provide for him, to help him. But now that he's 14 and I do see him struggling in school, you know, you still just want to be able to help. And we are at an age where I'm like, I'm not willing to just give up, but I also want to do something to be able to help. So I guess my question is I know it's no easy answer. I've taken notes and I've listened to everything, but do you have a suggestion of maybe at this point, try this type of, even because we've never done visual therapy. That is the one thing we haven't done. Right. So, but I also agree with the whole reading piece, and it's really reading and writing and that whole processing piece that we seem to be struggling with the most.
Right, right. Great question. Again, I'll ask Patty to give some comments on this as well. I think what I would say, particularly if you start getting into the adolescent ages, young adult, again, I want to be very, very clear that the window is not closed, right? As I said, plasticity is throughout a lifetime, but as we get older, we have to be that much more engaging, that much more intense, that much more creative in order to create those changes in the brain. So that's the first thing to think about. So what I would say in this particular case, what you described, not knowing more information than what you described, is really keeping that child engaged is extremely important. Finding things that they are particularly interested in and motivated in. Motivation is a strong driver for brain change as well. So really tapping into that, I think, is extremely important. And then the last thing I will mention is think about scenarios where that can be reinforced, right? So again, setting up that individual for success. On the visual side of things, really what's important to think about from a brain development standpoint is using visual information and acting on it, right? The brain is a two-way system. It takes information in and it acts on it. So creating tasks and scenarios where the child is not just passively watching things, listening to things, and hearing things, it's really about acting on this. So visual tasks, where there's, for example, visual motor integration, I think could be something very positive. Creating tasks where vision is a determinant of future decisions in terms of where that child walks or moves or anything, are all very, very important, because the idea here is that you're creating this feedback loop, right? That's where the connections happen. Taking that information in, acting on it in a predictable manner. And if there's a mistake, what happens is the brain learns from that, and then it calibrates accordingly. So you constantly want to create this feedback loop where information comes in, you act on it, and the child learns the consequences of its actions, right? This is true not just as a baby, but also, throughout life as well. So in this particular case, as adolescents, you want to find those scenarios where I think those changes will continue.
And I have, Tina, a couple of ideas for the age group particularly. So you just hear like act on visual information, doesn't have to be reading. And so one thing that, depending on the child, and these are, no effort is wasted, because an effort on an experiment is variability, which is what we were asking to have different experiences that they haven't experienced before. So for example, going hiking, but letting him do the guiding and then orientation and trying to find himself on a map, even if it's in the phone, maybe not using a GPS, maybe trying to learn the trails on a certain particular place. And this doesn't need to be a fancy park. This could be just going around the block to the pharmacy. So that's one thing that you could do, and he can try if this is something that entices him. The other thing that I think is really important, and we're gonna be working more and more on this, is adaptive sports. I mean, I don't know if he ever had a chance to participate in any sports before, but sports bring this constantly, like the visual, motor, sensory integration with the social motivation, the peer support, and having an adaptive sports coach. So I'm going to refer you again to Joe Walsh, which is Adaptive Sports New England. And even if you're not in New England, he may have ideas on how you could go into your local network. But having them move their body also decreases the anxiety and the attention deficit. There's a study in kids not with a stroke, but it shows that 45 minutes of physical activity a week, it's equal to Ritalin. So you can gain a lot of things that it might be very difficult, and he might have gotten into the habits of maybe getting so frustrated with working on homework, and then the attention is very low. And if they do exercise, that attention deficit can improve significantly. Maybe you see benefits just because of that. On top of that, I would say is one of the best visual integration things is to play sports. You have to catch a ball, you have to use your legs, you need to run from here to there, you need to, if you're swimming, any of these activities are really phenomenal to try. And don't think that he's gonna like one thing, he probably will switch from one thing to another one, or maybe he gets super into something. And we have a CP soccer team running at the time also in New England that Mara can give more information about.
Excellent. Could I just add, I'm sorry, because I couldn't agree more with Patty. I think there is tremendous neuroscientific evidence on the benefits of good cardiovascular health physical activity and brain development. This probably was cut off, unfortunately, at the end of my presentation. This was a study from the University of Granada that was looking at brain changes in a cohort of individuals who were, these are not kids who had brain injury, but a cohort of individuals who had extensive physical fitness and playtime and so on. And they found increased gray matter volume in parts of the brain responsible for language and reading, right? So they were playing outside, but the changes occurring at the brain were parts of the brain you probably wouldn't necessarily think about. So I think Patty is 100% correct. There's something to be said for physical activity, good cardiovascular health. We know that is a way to, again, prime the brain and respond to change as well.
And the most rich environment for visual input is nature, guys.
Sure.
That the weather itself changes the colors, the tones, the feelings, and it all goes accompanied by many multi-modality input. So even with the winter and even with COVID, this is one thing we can still all do in some extent.
Patty, there are a number of questions about the value of getting an MRI and at which age to target doing that, sort of relative to doing some of the interventions that Lotfi suggested.
Go ahead, Patty.
Yeah, most kids would have, if you have a diagnosis of stroke or CP, most of them have had an MRI at least one time, and most commonly around the time of injury. The acute injury in the brain, if there was no other follow-up MRI, and follow-up, I mean more than 6 months later, usually is not necessarily representative of what the brain really took as a hit. So a follow-up MRI is ideal. What we don't want, because we are not acting upon the follow-up MRI, is to have the kid going under anesthesia to get an MRI. So that, to me, to this date, because we're not changing management with those pictures, and I am a scientist too, and I would love to see pictures on how things end up happening because I'm trying to understand that. But my recommendation is there are places around the country in Europe, and I don't know exactly, I saw South Africa somewhere, I don't necessarily know all these places, but in many places, there are many hospitals that are able to do non-sedated MRIs with young kids. So if your child is able to be in the scanner with you inside, and there is a specialist, we call them Child Life in the US, that helps them kind of play through the scanner with maybe goggles and a movie or something, you may want to request a follow-up MRI. It all depends on the indication. For sure, the MRI is indicated and should be covered by your insurance or whatever healthcare you have if the kid has a change in his her exam. So for example, if you have seizures, if you have a change on something that they used to master and that they're losing it. So if there is a decline, you could also request to have a second look. But at the moment, we don't have a full action to do on what the brain scar looks like. We use the acute MRI, to be 100% honest, so you can go back and try to get that record to the person that is following your child right now and have them take a look at it. So that can be very instructive for the neurologist, for example, that is following your child. So bottom line, all of them have had an MRI. That's already very instructive of what potentially to expect as challenges in those networks that we're talking about. Follow-up MRI only if there is a change in exam or an event, head trauma also. And if you want to know, and the team that you're working with has the capability to do it without sedation, you may want to explore if there is any chance you can get a follow-up MRI to see what is the injury resulting in the brain.
Angela, are you still on to ask about your granddaughter? Jordan, are you still on? Shauna.
Yes, I am still on.
Oh, Jordan, go ahead.
Thanks. I thank you so much. It's such a concise and expert explanation. And thank you, Dr. Mussolino, Mara, Gretchen, for this whole series, especially Gretchen, for your family's story. So my son's almost 6 years old. He actually sees Dr. Barry Cran, who I highly recommend. Every single annual visit is so caring, really takes the time to understand, and very thorough. And I just, when you said dumper.
Okay, I understand it now.
Oh, Angela, Jordan's asking. Well,
oh, I'm sorry.
Oh, it's okay. Sorry. So when you said a dumper, I was like, that's him. He dumps everything out.
Yeah.
And he, you know, and I was like, but how do you know that is a vision thing or a motoric thing? It's harder to use control in both hands or a stage of development.
Yeah.
My husband's like, he's a 5. Or like a personality thing, you know, it's just so hard to figure out. And of course, like, with more complexity, definitely less patience, but he's not the type of kid who's going to do beating until like his fingers bleed, unlike my daughter, you know?
Right.
So how do you figure that out?
Great question. Thank you for sharing. And the answer to your question is we don't know. And that is exactly the challenge. You know, a lot of the work that we're doing right now, we've been working with kids who are very verbal, who, you know, have sort of insight into their visual impairment as well. And we do this for 2 reasons. One, because it gives us a sense of that two-way conversation. So when we make a modification or environmental manipulation, we can ask them, is your vision better? Is this easier? Is this harder? And we close that loop. It's a two-way sort of dialogue. The second thing, what we hope is that by doing this, by starting, quote, with this kind of population, that we can now sort of use that as cues to sort of march down to younger ages and perhaps, you know, non-verbal children as well. So that's a little bit our strategy, because we want to have that two-way dialogue. A lot of parents, for example, look at these presentations and say, oh, that's all well and good, but, you know, my child looks nothing like this, or my child is nonverbal, or I don't know exactly what my child is going through. And that is part of the scientific problem, is how do we know what we know? So what I would say in your particular, more directed to your question, is be your own scientist. When you do manipulate something, is it really that manipulation, or is it something else? So I'll give you a classic example. If I take out a toy of a particular shape and color, and all of a sudden that child's intention is really, really engaged, you have to kind of ask yourself, what is it about that toy that does it? Is it the color? Is it the movement? Is it because I put it in the visual field or part of the visual field that they can happen to see? It might be also a question of familiarity or emotion. Maybe they've seen that toy before and they've played with it. So what I say by being your own scientist is go into that deductive reasoning rather than just jumping to a conclusion saying, oh, well, obviously that's why. So you have to kind of think objectively. You have to be your own sort of detective to try to get into your child's head, so to speak, especially if they can't verbalize it or have insight into the nature of what they're doing. You really have to kind of think of it along those lines so that what you are seeing is really real, or the manipulations that you're doing are understandable and can translate to other scenarios. So that I certainly recognize what you're saying. It's very, very common. But that would be my advice to parents anytime I hear something like this, is don't jump to conclusions that what you did was necessarily the change that they needed or was helpful. Think about them, put yourself into their mindset, and try to understand what exactly that change did.
Thank you.
Sure. Great question.
I will add just a little piece, which is almost doesn't matter if we get it right, as far as you're trying different things. So you, for example, do this dialogue about where things are, and then also change the weight of what he's carrying. So you also give him proprioceptive motor, proprioceptive sensations. Like you can try to play, like literally the more play you make it and less of a recipe, the more success you're going to have, because even with the unknownness of where are we really hitting, you will see if it's something that works. Like,
so okay, it's like,
oh, this is what he needs. He needs me to, if he's carrying something, or we're going to do this activity, that I don't put it all together on the tray, for example, or what, that I do it gradually so he can sense that change of object. Or the height, like I put it in different heights, and we play with a toy that has heights, or we play with, like, these kind of things is all up for grabs. Is like what I am trying to encourage everybody is, like, make your life an experiment. And that is the message here, is like, there is no recipe. And you guys, believe me, we're not seeing the MRIs of all the kids that are in the call. We don't know exactly the specifics of their exam. So we don't want to pass any kind of recipe. We just want to empower you to think through, oh, hold on, they told me about this and this and this, so I should be maybe trying these other things. So no trial will be wasted, and you'll learn in that process what it may be really breaking it. Like, well, oh, maybe this is it. And sometimes is even having the hands have little gloves, like have parents that put a glove in one hand, not in the other, then change them, like just to have different sensations, color, you name it, weight, height, distance, and then the way you talk about it. Never in a right or wrong. There is no right or wrong. Just define it. Just as if you are like a radio commentator, kind of objective and kind of having fun. That's what the kid probably needs the most.
Thank you.
Yeah.
So we're going to take one more question from Angela and then let Patty close it out for those who are still on the call.
Thank you. Can you hear me?
Yes.
Yep. So I'm actually the grandmother of an almost 2-year-old who has CVI. She at 5 days of life got meningitis and was very, very sick and in the ICU. And halfway through the whole thing, she had a stroke in her right parietal lobe. And so we're, not that it really matters, but we're thinking, well, maybe it was the stroke that causes CVI. Who knows? My question is, how long does it take? How long do they say it takes for it all to settle out and you to sort of heal from the stroke? I know when my mother had a stroke at age 90, they gave some months or a year and said that's, she'll be improving and, as things heal. And I'm wondering with a baby, what would you say?
Angela, never.
Yeah. I don't think there's an answer to that. Yeah.
The truth, and I don't know, I think Lofty like touching it, neuroplasticity, we are using it at 80, 90 years of age, you still using it. So I know we have listen, I am in a adult neurocritical care with a ton of patients with a stroke that are adults. I know exactly how we think about stroke in the adult world, which is not the right way either. And I get it. We have as a healthcare assistant to put some goals and posts that we aim for equality, so to just try to give people the best treatment and accesses. But in reality, this thing that the journey of recovery ends at 6 months, 2 years, that is absolutely artificial. And any patient I follow in stroke changes and develops new interest and is maybe now, it didn't matter if they needed to use more or less the hand, but now they want to do a knitting project and they need it. And this is the time to address it. And the healing in terms of tissue outcome, it is probably being determined in few months after the injury. But I want to say something against that. Tissue outcome, meaning how these neurons and networks connect, it is always changing, like being taken down and being reestablished or tuned one way or the other by the learning experience. So if you think about outcomes and what happened after the stroke and the meningitis and everything, it really is not static. So we should, that's what I say, never settle it. And what also is happening is because developing is in the way. The new skill that is coming and arising as new things are being kind of mastered and troubleshooted. And what these kids are really amazing, the most resilient, best troubleshooters that I know in humanity. So they find ways around it. And as those other new functions that they can now access start arising, then you see new things. And what does it mean is that the injury is not static, meaning, yes, it knocked down something, but as this develops and it's a new network, you have to support that as if it was kind of a subacute new injury to the brain. It's not an injury, it's just like the healing process is the learning process, if you want to. So that's my answer to that. And with this, I'm thinking I'm gonna close. I do have to go also, and I know that a lot of you guys have to continue with your day. I so much appreciate the participation, and the questions are incredible also. Thank you, Dr. Mirabel, for this amazing presentation. There was a question in the...
What is this slide on? I'm sorry, because this was just the end, and I just wanted to show that to make sure everybody can see it.
Let me see.
Yes.
Great. I'm sorry, Patty, to interrupt. I just wanted to drive home that, please get involved one way or another as families. Studies going on all over the world, nationally, locally. I think that's extremely important. We learn working with you. It's, again, a two-way conversation. So please get involved. I'm showing you here the lab information for our group. And in terms of upcoming and future presentations, we do have people from Perkins on the call as well. I think that would be a great follow-up, as was mentioned. We also have Dr. Karina Bauer from our group, who does a lot of neuroimaging work. So I really look forward to keeping this this conversation going. Sorry, I didn't mean to interject, Patty. I just wanted to fit in this last slide.
No, perfect.
I know it got cut
and,
off.
And this is much easier. And if you guys are interested, through the emails that we use to communicate about these things, we can be sending all the opportunities. There are studies, and I want to say, if you're a baby from 0 to 36, and I'm saying this because the trial is still open, and you have some weakness in one hand from your stroke, there is a constraint-induced movement therapy study going on at Mass General and Boston Children's. Mara Yell is co-chair of the parent board for that study as well. So we will send, it's called I Acquire, and you might be familiar, and it's open and it's enrolling, and the therapists come to your house, even with COVID, because they get tested every day. Or not every day, they get tested appropriately. There is also the study that we were talking about, virtual reality with Danielle Levac. That's for older kids in middle school. And then we are going to be enrolling patients at Spalding, Salem, and Mass General. Dr. Mirabel has studies ongoing that you can participate in. The lab information is here. But what I will offer is that we maybe send an email of all the studies, and you see if you are interested, because your kid qualifies for the ages. So we'll send the criteria for each study and where to contact. So who's the person that you need to contact? This is a conversation that you need to have completely free. We think about research as a possibility of doing something for your child and for the future. So we have families that have excellent experiences participating in research, but it's always a one-to-one and a conversation, and there is a consent process and everything under the ethical IRB approval of the studies. And I think, Mara, am I forgetting anything? We are going to be having the Perkins specialist on our next workshop next month. So stay tuned. And auditory processing, I saw someone asking a question I wanted to answer. Is going to come after that. And we're going to have Dr. Floyd from Northeastern University helping us with how do we think about auditory processing and what can we do to help that domain as well. Mara, is there anything else that we should be covering that I forgot?
I'll just say out loud that there are lots of questions about the recordings, and we're working to set up a YouTube channel to share the video recordings as well as the website. One question that's going to come up is, can we share the Q&A? So we may need to get in touch with you individually for permission to share the questions, but we can certainly share the presentation. So we're going to share with you the links to all of those resources once they're available.
And there's going to be a survey after this workshop about the last 3. So whichever you participated, please give us feedback. This is what made this what it is right now, is only you guys telling us what you need. So please take the time to do the survey. It's not long. And in all the workshops you participated, give us as much feedback as you can. And any suggestions or any skills that you could bring to the group, we're always welcoming participation. So with that, I'll say good afternoon, evening, morning, middle of the night. I don't even know what time zones we have. And thank you so much for getting invested on trying to make this work as a community. That's what we really need to get our kids to thrive.
Thanks, everybody.
Thank you.
Thank you very much.